Now, we've talked a lot about waste reduction, haven't we? What's the single biggest budget item in the federal government right now? Medicare plus Medicaid. Okay, Medicare around $390 billion, Medicaid around $200, roughly $600 billion between the two of them, growing rapidly. So if we don't solve the Medicare cost problem, none of this makes any sense. Moreover, we can also reduce it for the non-Medicare, so it becomes a smaller part of our GDP. To that extent, I want to now introduce Nurse Karen Rago to tell you about some exciting, real-life cost reductions she has done that have led the whole healthcare industry. Karen Rago, please.
Thank you for that warm welcome. I'm going to demonstrate to you today that it's possible to employ Lean Six Sigma in healthcare. It is a challenge because our first obligation to patients is to do no harm. I will share with you 3 very different case studies that will demonstrate it's possible to reduce waste and cost while improving patient care and outcomes. Lean Six Sigma operations improvement in healthcare improves patient care and outcomes, removes waste and unnecessary care, it reduces costs to hospitals, and it can reduce costs to Medicare, Medicaid, and commercial payers. Implementing Lean Six Sigma and process improvements in healthcare takes senior leader support, which you've heard a lot about today. It needs physician champions, and it needs Six Sigma skills, department manager buy-in, committed analytics support, data and benchmarking, and alignment between medical center and physicians. The first case study was some work that I did, a group of us did at Stanford Hospital. Our problem was that coronary bypass graft surgery was very costly and our mortality was high. The solution was implementing operations improvement across the hospital and integrating it into all the planning that we did and our budgeting. We had cross-departmental teams, so hospitals are very much set up in silos. And putting teams together, so you had housekeeping, nursing, material supplies, the surgeons, everybody working together. We also had support with analysts and facilitators so that they could take a look at the data and they could feed the data back to the team so they could have feedback as to how they were doing. I said earlier, we had brainstormed ideas, and when I took it back to the nurses in the cardiovascular thoracic intensive care unit, and we asked them what ideas they had for how we could improve care and reduce cost, they generated about 130 ideas. So we took all of those ideas, we rated them on how easy we thought they might be to implement and cost savings, and we implemented 75% of the ideas. We also had the physicians review the ideas for feasibility as well to determine if they would negatively impact patient care. The results were our CABG mortality, that's the percent of patients that were dying, actually was reduced by 48%, almost in half. The cost of the case for taking care of somebody having the coronary bypass graft surgery was reduced in the first year by $2,400 a case. That was about 11% improvement. And over a 3-year period, we reduced the cost by 40%. One of the things that we were able to accomplish, just to give you a snapshot of what it took, we had all 6 surgeons sit in a conference room with us, and we opened up a surgical pack, which is the pack that's taken to the operating room. It has all their sterile instruments, the sponges, the sutures, everything that they will need for that care. And each surgeon, each 6th surgeon, had their own pack for coronary bypass surgery and their own pack for valve surgery. We sat and we went through every instrument, everything, every suture, everything that was in there. We would say widgets, every little thing that was in that packet. And by the time we were finished, we got the 6 surgeons to agree to a standard pack. So we had 1 CABG and 1 valve pack. That took a lot of waste out of the system. We also were able to look at the antibiotics that we were giving to patients, and we were using an extremely expensive antibiotic when a less expensive antibiotic that was just as effective could be used. We came up with protocols for reducing heart catheter utilization. So a catheter that's threaded in goes into your heart, and we put it in 100% of the patients. So we said, why are we putting it into 100% of the patients? About 25% of the patients don't really even need this. And when you introduce things like that, you introduce risk of infection, risk of clots. So taking it out reduces those risks and improve the care. Waste in healthcare. So there's waste in inventory. There's waste in excess stock or supplies moving around the system. There's also waste in having cluttered workspaces. As you can see in these pictures, they took the cluttered workspace, they got rid of the excess stock, cleaned it up, much better environment for the staff to work in. There's overproduction, unnecessary admissions, unnecessary tests, CAT scans, lab work, unnecessary blood that's given. The diagram in the bottom is a picture of where the heart catheterization goes in, so unnecessary having those catheters sitting in patients' heart. There's also unnecessary waste in transportation, moving patients around the hospital from place to place, different supplies and equipment that we use. Waiting for delays in diagnosis. Treatment, so patients who are in and there's a decision that they have to go to the operating room, but we can't take them to the operating room for 2 days. They sit in the hospital for 2 days. So it's making a system more efficient so that doesn't happen. Waiting for discharge. Do we have everything lined up so the patient can be discharged? Do they need home care? Are they going to a skilled nursing facility? Does their family need some help to be able to get them home? A lean hospital, what does a lean hospital look like? It's working to eliminate waste through having goals, measuring accountability, driving the improvement, making sure that the work areas are organized and arranged, training and empowering the staff. So throughout the entire organization, it is how you have to begin thinking about everything you do in your job. Smooth and consistent processes working in unison, problem solving, and then looking when a system doesn't work, quickly working through what didn't work about the system that you can make it improve. And working to get people to work, instead of in their silos, across departments to manage patient care, and getting everyone involved. The second case study is from the University of California, San Francisco, where I'm working now, and it was our sterile reprocessing. This is the system where they take all of the medical instruments that they need for an operating surgical case, and they put everything together to get it up to the OR for the next day's cases. So essentially, we have to do this for 100 cases a day. The process includes bringing the instruments down, cleaning them, the decontamination, then cleanly assembling them, putting them in the sterilizer, which is what this picture depicts, putting them in sterile storage, and then returning them back up to the operating room. So our problem was that the sterile instrument carts were inaccurate about 28% of the time. That meant that the first surgery in the morning couldn't start on time because the surgeon didn't have everything they needed for the case. The instruments needed to assemble these case carts for the next day's cases were still in the operating room, many of them, at the time that the shift started, so that they couldn't actually begin putting the case. We had people standing around doing nothing and then working overtime. So our sterile processing facts, we have 23 clinics and non-surgical units that they also prepare carts for. They audit 100% of the sterilized loads that they do every day. They touch 37,000 instruments each weekday, 195,000 instruments each week, about 1 million instruments each month, and over 11 million instruments each year. That's a lot of instruments to be touching. So what we did, they changed the start time for the instrument assembly for the next day cases from 11 a.m. in the morning until 11 p.m. So by the time that the staff came into work, they had everything they needed to begin to assemble the case carts. Efficiency improved by 17%. We reduced 14 people, 14 staff positions that were able to be redeployed. We didn't lay anyone off. During the same time, surgical cases increased by 5%. So we had a lot of things going on here that were positive changes. And the annual savings from reducing the full-time employees in this group and the overtime was $1 million, and it was a 16% reduction in labor costs.